go on to our next speaker, Dr. Mahipal SACHDEV, who needs no introduction, a very eminent refractive surgeon. And he's going to tell us about some of the testing times with Femtolasik. He'll be followed by Dr. Kumar, and I would request all of you all to make your talks as less than 8 minutes. And it's very sorry we are running late. And after Mahipal, Dr. Kumar would give some complex case scenarios. And then we would have our guest speaker, Dr. Mohammed Shafiq, who will be talking on customized surgery for refractive and therapeutic corrections.
Mahipal, you got 8 minutes, I got 6 minutes.
I'll take 4.
We'll take 4?
No, don't take 4. Our audience want keep it 8.
Anyway, good afternoon, everyone. Thank you for having me. I'm being transported back in time because I don't do very less of LASIK now, but let's talk about flap complications. So the complications of LASIK, as you know, can be grouped into refractive, laser, and flap related. So I'll be talking mainly about the flap related complications. One of the complications that you see more often, or you would see with LASIK, is as compared to SMILE, is a DLK. So this is you have to differentiate it from a central toxicity, or this is a diffuse inflammation comes as a sands of Sahara. The immediate thing in this particular thing is to, if it is of a higher grade, is to wash it and to clean the interface and maybe do a little bit of antibiotic and steroids at that particular time. And just the washing at times and high doses of steroids, which is topical and systemic at times with vitamin C, is what is required. Second is epithelial ingrowth. This is the epithelial cells which keep going in. Normally there is a track that can be seen. These are epithelial nests which are there. Relifted flaps always give rise to more chances of epithelial ingrowth rather than a fresh cut. You don't see this in a lenticular based surgery, but this incidence with the Femtolasik that you have and the flap, rather than being a beveled, the cut being, instead of a beveled, it being at about 90 degrees or otherwise, the incidence of epithelial ingrowth has gone down. AIOS2025, as you can see, is a good tool by which you can make out as to the extent of the epithelial ingrowth. These are 2 epithelial ingrowths. This is, I don't know, maybe 10, 15 years old. And this is this is not that old. So you can see there is epithelial ingrowth here. The key here is to treat early. This one came from some other center, not ours. And this is the track, as you can see here. The identification of the LASIK flap is important. You just lift up the LASIK flap. The important thing is to try to remove maximum amount of the epithelium which is there. So you can see here, this was the epithelial ingrowth which is being scraped. So scraping is one important thing. You can stain it with the fluorescein stain to see as to where it is. As you can see here, we are lifting it here in this particular case. Wherever there is epithelial ingrowth for a long time, you could have a stromal melt. So you have to be careful at that. Here you can see we are under surface of the flap. Also the residual epithelial nest need to be taken out. You can see this is liquefied epithelial nest which are here. Backside of the epithelium, washing it very well. And then there are 2 things that you can do. You apply mitomycin C, or you can apply absolute alcohol. It has also been shown that you can blow up the nest with YAG capsulotomy, but not capsulotomy, YAG laser. Then what we do is, after we have cleaned it up, we put glue, as you can see, glue. And once you put the glue, then you have to seal it up. You can see this is pretty edematous. We have removed from here. And I would always put a glue and a bandage contact lens. In case there is significant melt under those circumstances, you can also put a suture. So this is the same patient that you had, the earlier thick one. And this is 10 years hence. You can see that I still remember, she's a school teacher from Delhi Public School, and she had a bad time and we removed it, it was fine. One more thing that can happen is regression or ectasia. The 2 things have to be differentiated. In regression, you will have to see that there is no changes of irregularity in the topography, and the incidence of LASIK enhancement is about 5% in literature. For the lenticule, it is slightly lower, which is there, and depends on the optic zone, depends on certain factors which are unknown. It depends on the thickness of the cornea, etc., which is there. When you want to do an enhancement, you have to wait 3 months and maybe 3 to 6 months. Regular tomography with stable refraction is important. The AIOS-OCT is something which is a good tool where you can make out the flap thickness. At the end of the day, you have to know what is the residual bed thickness that is there, how much correction you have to do, and how much would be the residual bed thickness after the correction. If the flaps are very thick, like we had earlier with the Hansotome, you can do a surface ablation in these cases. While if you have adequate tissue, so you look at the flap thickness, you look at the epithelial thickness, you look at the completeness of the flap on the AIOS-OCT and calculate what is the RST, that is the residual bed thickness that is there. We can easily do a flap lift. People say you can mark with a 30 gauge needle on a slit lamp and then take a blunt spatula, and you can identify the where you need to go. But I have never used a needle, etc. All that you need to do for doing a flap lift is just use a sponge, dry it up, just press this. Can you see this? When you press this, this will come into play and enter the plane which is there. I have lifted flaps almost 15 years, 17 years post the thing. You can always, because this cleavage plane always remain. The only thing is that you can have an increased incidence of epithelial ingrowth, so you can relift and do this. Just be sure, wait a little longer for the flap to come back and sit back. Recut with a keratome on another flap, you can get lamellar slivers. If you get these slivers, we tend to throw them off. If you throw them off, you will get irregular astigmatism. So please do not throw. If you have to look at the chances of double cut. It is always better to know as to what it was, and you can go thicker and bigger. So that is what you can. But in case of a Femtolasik, you go smaller. So if you have a Femtolasik flap, you know the size of the flap, then you can reduce it and do just a fresh side cut, and you can relift that. So that is what needs to be done. In case there is post-LASIK ectasia, various factors which are there for ectasia, just to tell you, a corneal cross-linking alone in a post-LASIK cornea or a post-refractive surgery cornea will not work, because these are two dissimilar zones that you are trying to cross-link. You have to put in, I have no personal experience about cares, but you need to put in a segment, and I normally do an intax along with the corneal cross-linking or the same sitting. See, some people say you do a cross-linking, see whether it works or not, and then think of an intax. That is intuitively wrong. If you have something, you have a building which is tilting, you first put cement, you have frozen it there to whatever extent, and then you try to straighten it, it's not going to work. So you have to try to straighten it with the ring and at the same time put cement. So that is the thing, it has to be immediately one after the other on the same procedure day. This is the ring that I make with the interlace, you can see, and then go in with the clover leaf. Go in intuitively into the depth. You have to go perpendicular and then go in. Take the ring, which you can see, sorry, I just fast forwarded. You can see the ring, go perpendicularly and then thread it. You have to calculate 1 ring, 2 rings, what is the size of the ring, the thickness of the ring, and the arc segment. These are 2 rings. Put a girdle suture so that works as an artificial limbus, and then scrape up the epithelium and do the corneal cross-linking for them, and it works fantastically well. We have, this is a comparison which is there. I think it is the last one. This is a flap stria. Whenever you have a flap stria which is there for a long time, if it is on the next day or something, you can just pick it up and read this thing. But retroillumination, dilated pupil on a surgical microscope, clear thing is you have to remove the epithelium and long-standing flap stria. You can see the quantum of stria. They were never coming into play as such. After you have done, because the point is that the stria get anchored with the epithelium and they will remain there. So you have to then put distilled water to make the whole thing edematous. And once you have that, you will use to iron these. This is distilled water that is being put. You iron these, use these sponges, one side, other side. they stria never disappear on the table. Be very careful, you'll keep on feeling that why are they not going? They will at best become slightly less. But once you have done this, done the proper massage, put it, maybe use a little bit of a hot spatula and put bandage contact lens, the next day this is what you're going to get in the next few days, this is what you have, and the patient recovered good visual acuity. So friends, I think this is couple of the complications, how to manage them. And challenges are what make life interesting, and overcoming them is meaningful, I think. But we have moved on from the flap to either a surface ablation, to some cases to large number, and to the lenticular extraction. But those who are doing flaps, the chances of having these type of complications are there, but you can, with proper knowledge and skill, you can manage these complications. Thank you very much for your kind attention.
Thank you very much, Dr. Mahipal, for a very detailed